Good morning, and welcome to today's Moss Adams webcast, Medicare and Medicaid Value-Based Payment Models Update. Before we begin, I'm going to play a brief housekeeping video.
Welcome and thanks for joining us. Moss Adams webcasts are designed to help elevate your business performance. Transform your future for the better with advisory solutions tailored to your vision and supported by our collective technical resources. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget. You can ask our presenter questions during the webcast by typing a question in the Q&A window and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% or 3 of the 4 polling questions, which we'll ask throughout today's presentation. Polling questions will appear within the slide window. To participate in the polls, please click on your answer and be sure to hit the Submit button to record your response. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry, if you can't download your CPE certificate today, we'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our group CPE attendance sheet to receive credit. The attendance sheet is available in our slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit only can be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. As a reminder, the presentation you're about to see is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
Before we get started, I wanted to acknowledge our big news that Moss Adams and Baker Tilly are joining forces to create a new firm, one designed to serve the needs of the middle market. It's really exciting, and you can read more about it on our website via the link in the slide deck and handouts widget. With that, I'm pleased to introduce today's presenters from Moss Adams, Georgia Green and Rachael Peterson, both part of our healthcare consulting strategy team. I will turn it over to Georgia to get us started. Georgia?
Thank you so much, Jamie, and welcome everybody. Good morning and good afternoon. And I just want to reiterate from the video that you are welcome to put questions in our Q&A box at any time during the presentation. We'll do our best to address them. And if we can't address them on today's call, we'll follow up with you via email. And we would love to hear from you. No questions too big or too small. And it is a private chat box. Only the Moss Adams team will see that. So today we're talking about my favorite topic, value-based care and alternative payment models. We're going to talk about kind of some general notions of this transition to value-based care, talk about some changes we're seeing under the new presidential administration, and then we're going to talk through a lot of the current models that are active right now, just key things you need to know about those models. And we'll end it with strategic considerations for participating in APMs. So getting started, if you've been following value-based care for a while, you've probably heard of the 3-part aim, but that has expanded over time. So it started out with this notion of improving clinical quality, reducing the total cost of care, and promoting population health. But we have seen that expand into different areas that are related. So the notion of improving care access, increasing access, and improving upon health equity have been important over the last 4 or 5 years or so. We've also seen providing improvements to provider experience, also very important aspects of these models so that providers can really deliver the kind of care that they want to deliver, spending more time with patients, providing comprehensive wraparound services to patients. But I think just to simplify what is value-based care, I think of this value equation as simply quality over cost. So if you are improving quality or you're reducing cost, you are creating value. If you can do both of those at the same time, that's even better. But if you can do one or the other, that's still improving value. And that is CMS's goal in rolling out new payment models through the Innovation Center. So some folks are wondering, will this all get turned on its head with the new administration? And so far, that hasn't been the case. I've said for the last 10 years that value-based care is a bipartisan effort, and I still think it is, because everybody, no matter what side of the aisle you sit on, can benefit from having lower cost and more sustainable healthcare systems. We all want Medicare to exist when we get older. We all want Medicaid to exist to support the people who need it. So I think that it's totally bipartisan, and that is the goal of value-based care. So under this new administration, interestingly, just last Tuesday, they rolled out a new kind of strategy, vision to build healthier lives through evidence-based prevention, patient empowerment, and greater choice and competition. If you take a look at the Innovation Center's website, you'll see it's updated with a lot of information. And last week, Dr. Oz and Abe Sutton, the new head of the Innovation Center, went on a little media blitz. So you can probably find articles and webcast recordings with them talking about this. But just to put it in a nutshell, of course, protecting federal taxpayers is central to their mission, meaning that they are trying to save money and, reduce the cost of Medicare programs and healthcare programs in general. They have a focus on technology and data sharing that hasn't really been articulated in, previous generations or administrations. And a focus on embedding preventive care into the models. I heard them talk about focusing on rural healthcare providers and independent practices. And you can see here, they support the notion of site neutrality and expanding scope of care, supporting virtual visits or at-home care. And one thing that I think is very interesting is that they would like to require new models to have downside financial risk, and not just for convener organizations like ACOs, but for the providers themselves that are participating to also share in that downside risk. So that is something that we may see going forward. And they did say that we should anticipate seeing some new payment models over the coming months. And there may be revisions to existing payment models. So we may need to do this webcast again in a few months when new models come out. We'll keep you posted if that's the case. But all in all, I would say that the path that we've been on of testing these payment models, kind of getting, nixing the ones that don't work, continuing on with the ones that do work and expanding them, that is going to keep on keeping on under this new administration. They did already make some modifications to existing and proposed models. There's a link here to that announcement. I want to say maybe 1 to 2 months ago. They did end the models listed here early, and announced that there are certain models that they're not proceeding with that were previously announced. So there are some changes. I think this was mostly based on not having maybe supporting evidence for the efficacy of these models, or just they were close to their end dates anyway, so they just ended them early in 2025. Okay, so getting back to, what is value-based care? It's really all about shifting from fee for volume to fee for value. And the idea here is that you're proactively managing your patients. You're bringing your patients close. You're you're not just waiting for patients to walk in the door and deal with symptoms, but you're thinking about that whole patient and wrapping around a service of care coordination, integrating different members of your care team together, sharing information and a care plan, a centralized care plan for that patient with all the members of the care team. All value-based models have a focus on quality, so they all have certain quality measures that the participant is being judged on and awarded, based on performance. They focus on using data and steering patients to high-value providers. Often these models make participants think outside just the box, the four walls of their own clinic or hospital or health system, and you're thinking about everywhere that patient goes. What is the total cost of care for that patient, not just what happens in your clinic? And I have spoken to so many CFOs and, accounting type folks at healthcare organizations, and it can be a lot to wrap your head around at first. And you would say, why would we do this? This seems like it's maybe, reducing the care we provide or reducing our revenue. But in fact, that's really not the idea. It's really something that's beneficial to the patients, to your own employees, to think about, again, what's happening outside of your four walls, and if you can help modify what's happening out there. And I've heard plenty of folks say, we could, once we took this step, once we jumped in the boat, we could never go back to the old way of doing things. But certainly, folks can spend a lot of time with one foot on the dock and one foot in the boat, as, common metaphor, or, on that shaky bridge in between fee for service and fee for value. There are carrots and sticks with all of these models. And I think that, the general trajectory of CMS has been to offer big carrots historically, and we're starting to see the carrots get a little smaller and the sticks get a little bigger as time goes on, and they really want to, get people moving into these models. But in general, those carrots include things like predictable and prospective payments, meaning you're getting paid before you provide the care and you know what you're going to get paid, which can be a nice thing and allow you some flexibility in how you deliver that care. As I just mentioned, rewarding folks for delivering high quality care and for managing the total cost of care for their patients. Also, having publicly reported quality data, like on the Care Compare website with CMS, can be very beneficial to you if you are a high quality provider. They've offered new billing codes that really promote population health and care coordination. So basically they're saying, we'll pay you to do these things that we think are good for patients and overall keep them out of the hospital, prevent readmissions, and reduce their total cost of care. And we are starting to see the importance for CMS of not just Medicare fee-for-service doing this, because that may not be the majority of your patients, but having alignment between Medicare, Medicaid, and commercial payers that are all participating in the same kind of model with the same quality measures and making your life a little easier because of that consistency. Historically, a lot of the models have been voluntary. We're starting to see that shift more toward mandatory models, which we'll get into the details of that shortly. And the importance of this, given that the physician fee schedule is somewhat frozen, this is, a way to kind of make up for that gap. I'm not going to read through all the potential benefits of these models. The benefits are specific to each model. So this is just kind of an idea of the types of benefits you could be looking for when you're considering joining a model. Something I get excited about in many of these models, you get complete claims data about your patients. So you'll actually have a lot more transparency and see where your patients are going when they're not, again, inside the four walls of your clinic or your hospital. you can really see everywhere they're getting care and what Medicare paid for that care. With most of these models, there's the model-specific payments or those prospective and predictable payments. All of the models I can think of, you don't really have any change to your billing process. So you keep on billing just as you normally would, but you get a kind of an end of the year adjustment that CMS is calculating for you. So different models have different benefits. Could be positive impact on your MIPS score, which adjusts your Part B payment 2 years later. And it could just be that you're getting yourself prepared for the future of reimbursement. You see that this is the way things are going. You want to put in that care coordination infrastructure, that data and population health management infrastructure now so you can be prepared. This slide, again, I'm not going to read everything. I like to put a lot of information into these slides so that they can be a resource for you all. So when we send out the slides after today's webcast, you'll be able to come back and take a look. But these are just some of the things that we've observed as we work with patients across the continuum here at Moss Adams. You've got folks on one end of the spectrum who are not in any models and they maybe feel like they're getting left behind, and they just need some help with the startup activities. How do we set up this organization to do value-based care? How do we set up those programs? There could be folks that are in this for decades and really have their systems and processes in place, but just want to dial in some of the areas where they could generate more savings and a higher level of success in the model. So maybe that's looking at their post-acute care network, really finding those best referrals that they want to make for their patients to the highest value providers in that network. It could be managing length of stay, preventing admissions and readmissions. So, there's really everything on the spectrum, and everybody is somewhere on that spectrum, whether you're just getting started or you're old hat. There are always things you can improve to do better in these models. So with that, that's our first polling question, Jamie.
Thank you. The first polling question is, which of the following is not a potential benefit of participating in an alternative payment model? Your answer choices are A, financial rewards such as shared savings bonus or payment enhancement, B, exclusion from MIPS or favorable MIPS category weights, C, no requirement to report clinical quality metrics, or D, predictable prospective payments. We'll give you a few moments to respond. To participate, please click the button of your answer and hit submit.
Thanks, Jamie. So I don't see any questions in the chat box yet, but still just want to encourage folks to put those in there. If there's anything that I'm glossing over too fast, happy to circle back. Let's see our results. Okay, that is correct. Most people got the right answer here, that it is not a potential benefit of one of these models to not report clinical quality metrics. So all of these models are going to have some clinical quality metrics involved. So keep that in mind when you're in these models. There's payment benefits, but you also are reporting on quality metrics. And also, don't worry if you get a CPE question wrong, you're not scored. It's just a matter of completeness to get your CPE. So with that, we're going to dive into some of these models, and Rachel's going to kick us off.
Oh, thanks, Georgia. So to start, we have a few slides that are just going to go over examples of models that CMS has rolled out in the past. These here are all examples of voluntary models. They're either operational right now or ending soon and wrapping up in 2025. And some of these models are related to primary care, while others are related to specific specialties, such as kidney care or oncology. The BPCIA program is the predecessor to the team model, which I'll talk about shortly. And you may have seen or heard these before, but like Georgia mentioned, we just wanted to list these out with some more detail to have as a resource for you all. I'm not going to get into the details of the models today, but yeah, just giving a brief overview of some different types of value-based payment models that have been made voluntary in the past. And then here we have some mandatory models from the Innovation Center that have recently ended. One's wrapping up in 25 and one is still ongoing. But again, not going to get into the details, but here's a little bit about those models.
Excellent. Thanks so much, Rachel. So first, I want to talk about the Medicare Shared Savings Program. This program is very near and dear to my heart. It's the largest accountable care organization, or ACO, program in the country. In 2025, there are 476 Medicare ACOs providing care to over 11 million Medicare beneficiaries. And in 2023, the last year that data is available, those participants earned $3.1 billion. So this is a very kind of prevalent program. You can see it's all over the country, and it is a permanent program. So this is not really being tested. It's something that every single year you have the opportunity to apply we'll go through the timeline, but during the summer to participate in the upcoming year. So how does the program work? It is a transitional payment program. Like all others, the idea is to make Medicare financially sustainable. And this is really focused on population health, care coordination, and primary care. So primary care providers are really the main participants or providers that are in this in the ACO. And the idea is that the ACO acts like an umbrella organization, hence my little umbrella clip art here. I always think of an ACO as an umbrella, and it might have one participant tax ID number under it. It might have 20 or 50. It doesn't matter. You can have as many folks under the umbrella as you wish, but you all come together to become accountable for the total cost and quality of your attributed patient's care. Again, whether that's within your four walls or all of your four walls or anywhere they go. So wherever the patient goes, Medicare is going to count that into the cost of the patient. Patients will be attributed to you if you provide the plurality, that's just a fancy word for the most dollars of primary care within the ACO as opposed to outside the ACO. And they still have total freedom of choice. They're still Medicare fee-for-service patients. They can walk in the door anywhere that accepts Medicare, go where they want. But if they're getting more of their care from ACO providers than external ones, then they'll be your patient. And what CMS does is they look at 3 benchmark years and compare them to each performance year that you're in the model. And we'll take a look at kind of a visualization of that in just a moment. There are different levels in the model, A, B, C, D, E, and enhanced. And if you're at the bottom 2 levels, A and B, that used to be called track 1, if you've been following this for a while, it's really just a bonus-only program. There's no downside risk. So if there's no penalty, and you can stay, if you are new to the program and qualify, you can potentially be in that level AB for up to 7 years. So it's a very long time you can stay in the program and get your training wheels on and get your systems in place. And it's really just upside only. There's only potential for a bonus payment. There is annual quality reporting. And like I mentioned before, your billing and reimbursement process does not change at all. You keep billing and getting paid from your MAC exactly like you get paid today. It's just an end of the year calculation that CMS does. And just conceptually, what that looks like is, let's say they look at all your patients in those benchmark years and say, the spending per year per patient was $10,000. That's your benchmark. But now you're in the MSSP. You put in all this effort on care coordination, on data reporting, on quality programs, and you reduce your patient's cost to $9,500 a year. Well, that $500 that you just saved Medicare, if you were not in the program, Medicare would just take that $500 and say, have a nice day. But by being in the MSSP, you share those savings, right? That's the idea of shared savings. And depending what level you're at, that impacts your sharing rate. So if you have a 40% sharing rate, you would earn $200 per patient. And then you would multiply that by your quality score, which would result in your ultimate payment. So here it's just showing if you had an 85% quality score, you'd end up with $170 per patient. So that's kind of in a nutshell. If you're visual, this might help you out to understand very roughly how the program works. You do need to have 5,000 attributed lives to be in an ACO. And that's why so many independent practices that are not that large join into collaborator ACOs and have kind of a convener entity that oversees them. You have to be Medicare enrolled, of course. And the program, MSSP requires that you implement certain programs around quality, promoting evidence-based medicine, providing care coordination for your chronically ill patients, promoting patient engagement or patient satisfaction, like they have a CAPS survey that's sent out, and having a data warehouse and data management capabilities. But there's total flexibility in how you implement those programs. So one ACO does not look like another ACO. Each one's unique and each one can implement their programs in their own way. Here's a timeline for this upcoming year. And just, in the beginning, of course, you want to, educate potential stakeholders in this, see if participants are interested and qualified to participate in the program, do some initial strategic, operational, and financial planning, establish your ACO entity. This is kind of the basic get yourself set up to apply kind of process. And you'll need a contract. So you need a participation agreement between that ACO umbrella entity and each participant TIN that's in the ACO. Then the application itself has certain windows of time where the portal opens with CMS, and the portal, it is set in stone, these dates. So be very mindful, because they also tell you the times in Eastern time. It's usually, midnight Eastern time or 9 a.m. Eastern time. So just be aware of those, maybe noon Eastern time, but it's 9 a.m. Pacific. So be aware of those exact deadlines if you are planning to apply over the summer. But there are a couple of phases here with RFIs, requests for information. It ends with an e-signature event in December, and then you start the program on January 1st. So certainly have done many of these applications. I'd be more than happy to help anyone who needs assistance going through this process. Okay, Rachel, will you tell us a bit about ACO REACH?
Of course, yes. So ACO REACH program, it's not open to new ACOs. However, hospitals or clinicians can join existing ACOs that are participating in the program. We are seeing some of the participants in this program drop out. Last year, there were 122 ACOs participating, and you can see this year there is 103. It's similar to the MSSP program, but a little bit more intense. It's similar type of program where they're managing the total cost of care, but it's differing by CMS. CMS is offering those upfront payments. So it's a little bit more higher risk and higher reward program than MSSP, and it also has capitation payments. And then we will pause here for our second polling question.
The next polling question is, which statement about the Medicare Shared Savings Program is true? Your answer options are A, an ACO's 3-year benchmark period changes every year. B, ACOs have a special billing and reimbursement process. C, ACOs have flexibility and how they meet program requirements. Or D, ACOs that do not earn shared savings will owe Medicare a shared losses payment. give you a few moments to select your answer. As a reminder, if you'd like to receive CPE credit for today's webcast, you'll need to respond to at least 3 of the 4 polling questions.
Thanks, Jamie. And we're starting to see some questions trickle into the box, so thank you for that. One question is just, what does ACO stand for? So that is Accountable Care Organization, and that is the umbrella entity. So that entity kind of sits between CMS, then you have the ACO, and then you have the participant tax IDs that are Medicare enrolled tax ID numbers, or TINs, or the providers. So all your providers kind of roll up under that ACO, Accountable Care Organization. I see another great question here about if an organization's just starting to consider MSSP, is it better to wait until 2027? I think that you could, as of right now, it really depends how far along you are. You could certainly open up an application in that first period, the RFI, initial period, and start educating your leadership and see how quickly we can get a contract together and get your participants signed on. But typically, folks need a few months to kind of get that all set up, create the entity. So it really just depends on your specific situation, if you need to create a new entity or how much education you need to do for leadership, board, and operators. But it's certainly doable. You're not too late to set up an ACO for 2026. And looking at our results, we got kind of a mixed bag here, but what we were looking for is that third one, that ACOs have flexibility in how they meet program requirements. So even though there's kind of broad requirements for MSSP, you have a lot of flexibility in how you meet those requirements. Okay, moving on, we're going to talk about some of the newer models. MSSP has been around for a decade or so, more than that. We're going to talk about some of the ones that are a little bit more fresh as of the last couple years. So the first one is a mandatory model. It's called Increasing Organ Transplant Access, and it is for non-pediatric transplant hospitals. And the idea here is to increase the availability and efficiency of kidney transplants through performance-based payment incentives. So just like any kind of pay-for-performance program, CMS is measuring certain quality measures. And you can see there's 3 listed here. Achievement, that's the total number of transplants relative to your hospital's target. Efficiency, the organ offer acceptance rate. And quality, the post-transplant composite graft survival rate. And I am not a clinician, so I'm not gonna tell you exactly what that means, but obviously it's a quality measure related to how well the kidney transplant goes. So they look at that, they come up with a total quality score, and then based on kind of where you sit in that quality score, 1 to 100, that will determine if you're in the upside group. You can earn up to $15,000 per transplant, the neutral group with no payment adjustment, or the downside group where you owe CMS up to $2,000 per transplant. And that starts in the 2nd year. So they do give you 1 year to kind of get your training wheels on, see the data, see how you're performing, and then those downside payments will start in the 2nd year. And like any model, there are certain compliance requirements for participating in this one that those 103 selected hospitals need to do, reporting certain data points on their website, and reviewing the transplant organ offer acceptance criteria with their waitlisted Medicare patients at least once every 6 months. So again, this is only relevant to those 103 hospitals, but it is an example of a mandatory program, and it's kicking in very shortly in about 6 weeks here. So if you're not sure, make sure you check the list. And also I should mention, if you're not sure if your hospital is in some of these models, feel free to put questions in the chat and we can follow up with you and look into that and confirm for you. Okay, Rachel, please tell us about the team model.
Yes. Okay. So the team model, it's actually the transforming episode accountability model, but it's more commonly or maybe fondly referred to as the team model. This model, it's also a mandatory model. It was assigned to just over 740 acute care hospitals across 188 core-based statistical areas. So if your hospital is in one of those CBSAs, you will be participating in the team model. Hospitals could also voluntarily elect to participate. In their most recent list of participants, there were 10 voluntary hospitals. But this model is starting on January 1st of 2026, and it's set to run for 5 years. It's for patients that are undergoing one of the 5 surgical types that we'll show in just a minute. But the idea for this model is for hospitals to become accountable for and responsible for the total cost of a patient's care from the anchor stay and then the 30-day episode after discharge. So this is for patients within Medicare fee-for-service, so they're free to go to any provider that they would want to. And then at the end of the 30-day episode, CMS will add up all the costs of the patients and compare it to this target price. And after that, it's pretty simple. If the combined episode cost is below the target price, CMS will give the hospital a payment. However, if it's above the target price, the hospital will owe CMS a payment. So it's both up and downside risk. And you may be wondering how CMS comes up with this target price. It'll start out with a regional price for each surgical type, and then it'll be multiplied by certain factors that are specific to the patient and the hospital itself, and then multiplying it by a normalization factor and a trend factor. And then it's multiplied again by a CMS discount, which is either 1.5% or 2%, depending on the surgery type. And another thing to note about the team model is that there are 3 different tracks within the model, and they all have varying levels of risk. The hospitals are able to choose which track they'd like to join dependent on their category of hospital. And then here we have the 5 surgical types that are in the team model. So each one of these DRGs or HCPCS codes will have an episode target price that the participant hospital will be working towards achieving. And another thing to point out here is that some of these are only inpatient surgeries, while others can be performed in an inpatient and outpatient settings.
Excellent. Thank you so much, Rachel. And I just want to address a question in the chat that caught my eye, a question about whether payments are based on HCCs or hierarchical condition categories. And the answer is yes. Most of these models incorporate HCCs for risk adjustment, which then impacts your payment in the model. So it is important to know that you're capturing those HCC codes and sending them to Medicare in order to get the correct target price setting in the team model. And it also affects your benchmark in MSSP and ACO REACH. So getting good at HCCs, using the most up-to-date version, which is now version 28, those are all important things to consider, and really training your primary care providers and specialists to code all the HCCs that they're treating. Okay, so those were our 2 mandatory models, IOTA and TEAM, and those were both hospital-based. The next models we'll talk about are not quite as hospital-focused, so for those of you that may not be representing hospitals today, stay with us. And these are voluntary models. So GUIDE is Guiding an Improved Dementia Experience model. It's an 8-year model. It's got 350 participants, and it is not open to new applications right now. But the idea of this one is about providing dementia care, focusing on care management, coordination, and support for Medicare beneficiaries and their caregivers. And you can see there's multiple payments here. There's upfront infrastructure payments, a monthly care management payment, and 3 new G codes for providing respite services. And as with other models, there are certain quality measures that CMS is looking at. Our next model is the Innovation in Behavioral Health model. Again, this is another 8-year model, but it is only available in 4 states. Those are Oklahoma, Michigan, Western New York, and South Carolina. And this is, as it's named, focused on behavioral health, but this one crosses over with both Medicare and Medicaid agencies. And it's really the state Medicaid agencies that applied to CMS to participate in this model. And then those Medicaid agencies partner with Medicaid managed care organizations and directly with mental health and substance use disorder agencies in the state. So this payments, they offer infrastructure funding payments, an integration support payment, a performance-based payment, and the Medicaid agency will offer its own, kind of performance payment as well. So if you are a community mental health center, a public or private practice, an opioid treatment program, or safety net provider doing any of these behavioral health or substance use disorder treatments, and you're located in one of these 4 states or regions, then I would keep my eyes peeled for this and maybe reach out to your Medicaid agency to see about participation. We have the AHEAD model, States Advancing All-Payer Health Equity Approaches and Development. And you see the word all-payer in the name there. That's because CMS is focused in not just on Medicare, but also Medicaid. And they're also requiring that commercial payers be aligned in this model as well. So it's a multi-payer total cost of care approach. And I would say maybe the most interesting thing that jumps out at me in this one is that the SMA, the state Medicaid agency, will set a hospital global budget. And so Medicare and the SMA will set a hospital global budget for the year. So you'll get enhanced payments, capitation payments, predictable prospective payments, but they will be operating under this global budget idea. And we are expecting to see a hospital global budget tool to be released this summer. This is only in 6 states. So if you are in Maryland, Connecticut, Hawaii, Vermont, Rhode Island, or specific 5 counties in New York, I think it is the New York City area, then you would be eligible for this one if you are, a hospital or primary care provider. And that includes FQHCs and RHCs. So again, if you're located in those states, this may be something you want to look into as a voluntary, participation option for those enhanced primary care payments and for those prospective, predictable payments for the hospitals. Our next model is Transforming Maternal Health Model, TMA. This is actually a 10-year model. It's already underway in 15 states. We're going to test my knowledge of state initials: Alabama, Arkansas, California, Washington, D.C., Illinois, Kansas, Louisiana, Maine, Minnesota, oh boy, Mississippi, New Jersey, Oklahoma, South Carolina, West Virginia, and Wisconsin. And again, this one's focused on maternal health. So if you are a maternal, prenatal care provider, if you're a hospital that delivers babies, then this model is potentially for you. And it's, again, a model that the state Medicaid agency applied for. So those state Medicaid agencies are really the ones running it and will provide information to you about how you can get involved and you can participate. This is just Medicaid. It's not a Medicare model. There are certain, let's see, the state will allocate its cooperative agreement funding out for infrastructure payments and upside performance payments based on your quality performance. And you can see the quality measures here, things like low-risk cesarean deliveries, trying to minimize those, the timeliness of prenatal and postpartum care, screening for depression and follow-up plans for maternal patients, and then severe obstetric complications. So you can see this is a potentially interesting model if you're providing maternal care and you're located in those states. And then one last thing I wanted to touch on, because many of our clients were participating in the Making Care primary model. This is one of those ones that we mentioned at the beginning of this webcast that is being closed out a little early, actually a lot early. It just got started. And this will be kind of the end on June 30th, 2025 this year. So all participants will be kind of disenrolled as of June 30th. There's no ability to withdraw early. Let's see, I would say the main news here is that the reporting requirements for those participants are suspended. So you don't need to report on your usage of your upfront infrastructure payments that you've received. You don't need to report on health IT and patient sociodemographic data, care delivery, or quality. And that includes the annual quality reporting requirements like ECQM or CQM measures, patient-centered primary care measures. All of those reporting requirements are suspended. But there are some compliance components that you still need to do to close out the model. So they did provide template notification letters, a letter for your patients and a letter for your providers that need to be posted by May 31st. So that's coming up very quickly here. If you're in the model, please make sure you've got those template letters and you're sending them out as needed. There will be a financial settlement report that comes out in August. And within 30 days of receiving that report, you need to submit back to CMS a certificate of disposition. And that's basically just saying that you have disposed of all of the data you received in the model. If you owe CMS any money, then you'll receive a demand letter, and they're estimating those will be sent out around September 26th. And you have 30 days to cut a check, make that payment back for any monies owed. And that basically the final report that you get from CMS will have patient level data that explains why you may owe money to CMS or may be owed money. So it could go either way. This in and of itself kind of merits its own webinar. So we actually do have a slide deck. If you're in the model and you would like really more detail about this, please reach out. We have a 30-minute presentation we can give just specifically on this topic, which we've scrunched into one slide here, but I'm certainly happy to provide more detail to participants who want to make sure that they're crossing all their T's, dotting all their I's as this model closes out. And with that, we'll go to our third polling question.
Which model is mandatory for hospitals located in randomly selected regions? Your answer options are A, transforming maternal health model, B, transforming episode accountability model, C, states advancing all-payer health equity approaches and development model, or D, innovation in behavioral model. We'll give you time to select your answer. For those of you that would like a copy of today's slide deck, you can download them from the folder that says slide deck and handouts. We'll also be sending the slides and recording via email tomorrow.
Thank you, Jamie. And just looking at our chat box here, I see a question about, if you have 25,000 members, would it be better to be a standalone ACO or join a convener or aggregator? And that's such a great question. That's exactly the kind of consulting question that we work with our clients on to look at your specific situation. Certainly, if your entity on your own has 25,000 Medicare fee-for-service lives, we could help you figure out how many of those will actually be attributed to your ACO, because it's not going to be 100%, but you're certainly well above the threshold of 5,000 lives needed to participate in the MSSP to be your own ACO. And I'd be more than happy to walk you through the pros and cons of why you would do your own ACO versus what benefits you might get out of joining a convener organization that might be taking some of the risk out of the equation and might have tools to offer you. Okay, so looking at our results here, the correct answer is the team model, the second choice here. This is mandatory for hospitals located in 188 CBSAs, that's core-based statistical areas, or basically metro areas. Some examples of ones that were selected are the San Francisco Bay Area, the San Diego area, the Boston area, the New York and northern New Jersey area, Denver, but also some smaller cities as well, like Klamath, Oregon. So just if you are sitting in if you are a hospital that performs those 5 surgeries, any of those surgeries, and you're sitting in the randomly selected area, then you are mandatorily in the model. Okay, we're going to move on. I know we've got limited time here, so let's talk about strategic considerations. Maybe you listened to everything we said today and you're just thinking, we're not ready for any of that. That's okay. That is totally understandable. But you can be doing things today to get yourself prepared for participating in one of these models in the future and position yourself to succeed in the future. So you can be working on your MIPS quality score and thinking about kind of the common quality measures that factor into these models payments, and just work on quality. That's just kind of nuts and bolts. You can be increasing your IT capabilities, particularly making sure you transition to certified EHR technology and start working with HIEs, health information exchanges, or moving your data into APIs. So you can be prepared for receiving and also sharing data if you do work with other organizations on this in the future. Someone brought up this question, and I just want to underscore here, increasing your HCC coding specificity and accuracy, making sure you're coding correctly and to the highest level is really going to help you with your payments, because it really does impact the target setting and benchmarking processes that CMS uses in these models. And also promoting population health. And what do I mean by that? CMS offers a suite of billable preventive care services that can help promote population health. That means taking care of everyone, not just the sick person right in front of you, but you're working with patients to detect disease early and manage them so that their disease progression is slow or reduced, and kind of keep those patients out of the hospital. It's about proactively reaching out to patients. Have you had your preventive care? Have you had your vaccinations? Have you had these different screening tests? And using that team-based care approach. So here's a list of examples of Medicare services, and many folks that we work with maybe are kind of loosely aware of them, or maybe you even do a lot of this work, but you're not necessarily checking all the boxes so that you can bill for it and get paid for it. So that's another thing we love to work with folks on, just looking at that opportunity and helping you set up the programs or workflows so that you can do these things and get paid for it. I also would say there are a lot of models out there. Today, we mostly just talked about Medicare and Medicaid programs, but of course, commercial payers offer their own version of these things. And so you might be thinking, wow, there's just a lot of choices. How do I pick what to do? What's the right fit for us? And that's where we can come in and help guide you through it a bit. But, the process here would be to make sure you really understand always how this model works. What are the rules? What are the requirements? What's the math behind it? And make sure there's no, kind of tricky things that you're going to get stuck on. You want to think about who is going to participate. Is it an entire clinic? Is it a subset of certain doctors or advanced practice professionals within the clinic? Are there multiple entities that are partnering together that maybe have never worked together before? So you want to think about the who. You definitely want to develop a detailed budget that kind of shows what you expect your operational costs to be and best case and not so good case outcomes from that. And think about, strategically the broader landscape of you doing this. What's happening in your market? Is there a long-term benefit that outweighs maybe some of the short-term costs? Because you do have to invest to get into some of these programs. Okay, this is our last polling question, but don't take off quite yet.
Question number 4, where is your organization on the path to participating in a Medicare or Medicaid alternative payment model? Your answers are A, we participate already, B, planning to apply, C, interested, but we need to learn more, D, we're out. Our organization will not join an APM voluntarily, or E, not applicable. Once you have completed all CPE requirements, you'll be able to download a PDF of your CPE certificate from the CPS progress window. This will also be emailed to you at a later date. Looks like we've got about half of our respondents in, so we'll give it a few more seconds.
Thanks. Yep, get your answers in and get your CPE. I do see a couple interesting questions here about primary care, especially because primary care first and making care primary, 2 of the primary care focused models are over. They are canceled. And so a question about, do we think a new model is going to be introduced? I think it's very likely that a new model will, especially because this new administration has said that their emphasis, their focus is on preventive care. So I could definitely foresee a new primary care model for providing advanced primary care services coming out within the next few months here that does require downside risk for providers, but is primary care focused. I would expect preventive care to start, we're going to start to see that be integrated into all of the existing models even more than it already is. So that might be new quality measures. Okay, so wrapping up, just want to share that we're happy to support you wherever you are on this journey of value-based care adoption. It could be that you just want some help understanding the rules and timelines for a new program. We can help with designing the operations and systems for you to succeed, budgeting, financial planning, helping with contracting, getting into performance analytics, of really ingesting that claims data that you're getting and helping to derive some conclusions from it, compliance, quality reporting, whatever you feel might be a gap in your current value-based care suite of services. We're happy to help you fill that gap and succeed in these models. Okay, Jamie, can you share with us about our resources?
Yes, we've provided some resources for you all. These will be emailed to you in the slide deck handout tomorrow. But on June 4th, we have our next webcast covering cybersecurity threats. If you're not currently subscribed to our Healthcare Content Hub, here is a link that you can click to subscribe and make sure you get all of our healthcare insights. Finally, Registration for our 2025 Executive Healthcare Conference just went live this week. Highlights include a Women's Executive Healthcare Leadership Forum. We will have our State of the Union political point counterpoint with our keynotes and an economic forecast. It is in November in Las Vegas, and you can scan the QR code to go to our website and learn more. With that, thank you, Georgia and Rachel, for a great presentation today. If we didn't have time to answer your questions, we will do our best to follow up with you after the webcast. As a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in the slide deck and handouts window. If you participated as an individual and met all certification requirements, your certificate is available to download now in the CPS progress window. I'll keep the webcast console open for a few minutes to give you time to download that certificate. A copy will also be emailed within 3 weeks should you have any difficulty downloading now. Finally, here is a link to an online survey where we can provide feedback for today's presentation. We'd be grateful if you'd take a moment to complete this survey, as your feedback is very important to us. Please also visit mossadams.com for future podcasts and other resources to help elevate your performance. Thank you for joining. Hope you'll join us again next time.